All right, so this is just a very short voiceover over the content that we didn't get to yesterday in health assessment. So, cultural care implications. So, some additional questions that you might consider during the complete health history is cross-cultural, like we said, implications, their biographical data. Where have they come from? How long have they been here? Under maybe what circumstances have they come to the United States? And also that falls under that is their spirituality and their religious affiliation. And then that falls into, are there certain procedures or care that cannot be implicated based on their cultural or to a more extent, their religion or their spirituality, such as blood draws, blood administration. And I think immunizations might be a big topic if they've come from another country where the standards are not where we are at the United States as far as through the CDC. There may be some other immunizations that they actually have received coming from another country. So those are things to critically think through when you're doing a complete health history. And then, how do they perceive health? Can they describe what health and illness or even wellness means to them? And then, like we said, nutrition, that may also fall with the certain procedures and treatment that can be done. So, is there certain meat products that they need to avoid? Dairy products. And then review of systems. This is an important component to remember. This is not objective data that we're collecting, and you won't be doing it this week with the assignment that you're working on. But on subsequent weeks, you will. It will be a component of the subjective data that you collect with your patients. So the ROS, so the review of systems, right, we said is subjective information. It is not objective data. It's a head-to-toe fashion of subjective complaints that we might see in patients based on specific body systems. So skin, are there any lesions or open areas? Eyes. When was the last time they had their eye exams? What's their vision screening results? Do they wear glasses? Do they have any problems with tearing or double vision? So not only is it subjective complaints of each specific system, if it's applicable, it's going to be health promotion activities. So, right, under eyes, when was the last time they had an eye exam? If we're looking at the mouth and throat, when was the last time they had their dental exam? Do they wear dentures? Are they having problems with their dentures? So it's subjective complaints in addition to certain applicable topics. It's going to be health promotion activities. Just make sure with the review of systems, we're not collecting objective data that we've seen. We're not putting it in there. And so in addition to being a little bit more thorough and complete with a health history, if the patient comes in and their chief complaint or they're presenting complaint, they may have forgotten some things. So this is another area where we can be a little bit more thorough. Okay, so our functional assessment, if you look under the handout section for week 1, you see that there's a Word document for Gordon's functional assessment. So this is more geared towards nursing. It allows us to be much more holistic in our assessment data. It's more about self-care ability in specific areas. It's pretty in-depth, and the part of it allows us to be complete, holistic, and the suggestion is that we incorporate it into complete health histories. And in the grand scheme of things, it allows us to identify accurately and completely patients' problems so we can formulate a care plan based on what we find. And again, this is probably not something you're going to be doing this week with your complete health history, but as you move through each week and you focus on your lab worksheets, you're going to see that some component of this is going to be within your information. And then so some things, obviously perception of health, that we're looking at when we're collecting subjective data. How does the patient define health? And we know that that can be a varied picture. Some, it's optimal wellness, whereas others, it's just that they're able to get to work, that they always have some underlying complaint or health impairment, right? So it's at two ends of the spectrum. So how do they view their situation now? Do they have a good quality of life, or they're barely getting out of bed and functioning? What's their overall concerns? What are their health goals? And what do they really expect from the nurses and the doctors? Right, so looking at cultural competence, and I know you guys talked about this a little bit with Professor Needham and Mrs. Keegan yesterday. All right, so immigration and healthcare concerns. So what's our issue with cultural competence? Okay, so some patients with limited English proficiency, they have very minimal understanding of the modernization of the healthcare delivery system in the U.S. They may have not a good understanding of medical and nursing practices and interventions. And then obviously overall, maybe they just have limited English proficiency with the language. So their ability to understand broad concepts and specific nuances of the language. Okay, so we need to make sure that we know all of those can factor into the patient's outcomes, that we're tailoring to the patient's needs to improve those outcomes and their safety and the quality of care. All right, so according to the National Cultural and Linguistic Standard Components, there are 3 things that we need to keep in mind when we're caring for patients of a different culture who has maybe some limited English proficiency, or they have just newly migrated to the United States, right? These patients deserve effective care. They deserve respectful care, and somewhat cultural linguistic competence by us as the healthcare profession. So effective care, right? We know that this is going to improve their outcomes, and the patient is going to be much more satisfied in their family. Because in this, we know, is going to help to build a more solidified, trusting rapport with these patients. Respectful care, we need to also consider their values and preferences when we're implementing care. What does the patient need? And so, it is really the law. So Title VI of the Civil Rights Act of 1964 tells us that services cannot be denied to people of limited English proficiency. And so right now, 21% of the Americans older than 5 speak a language other than English, and we know that that's most commonly Spanish. Okay? So we know that patients who have limited English proficiency, what the evidence tells us is they are at risk for poor outcomes. And so we need to make sure, and we did talk about this a little bit yesterday, that healthcare facilities have to have 24/7 established interpreters who can assist with therapeutic communication with people who have limited English proficiency, which means that 24/7 in a hospital, whether it's by phone or in person, we need to be able to have access to interpreters of various languages. It's the law. So for your exam, and I think for caring for patients, you need to be able to determine the difference between culture and ethnicity. And I think that's on your test blueprint. So we know there are 4 characteristics of culture. It is learned, right, through language acquisition and socialization. So through our social experiences. It's shared, and it's adaptable, and it's dynamic, and it's depending on, right, our environmental factors and the resources that are available. So sometimes we think of culture, we think of it's the individual, right? And it's all those components, the thoughts, their communications, their beliefs, their traditions, and then that falls under their association with race, ethnicity, religion, or social groups. So culture is more of that broad concept of who is the patient. And we know it's composed of 4 characteristics. Don't forget it. They're learned, shared, adapted, and dynamic. And so it's a little bit different than ethnicity, right? So culture can almost fall under ethnicity. And so concept is not necessarily tangible, right? It's a broad concept For ethnicity, we know it's a specific group that's going to be united by the following traits. So we think of it as race, language, religion, and then we said shared values, traditions, or symbols might be more in line with culture. So culture tends to fall maybe under ethnicity. So ethnicity is much more tangible, it's observable, whereas culture is much more broad and it's the entire patient. So be able to know the difference between culture and ethnicity. And then religion, spirituality, I think, we know a little bit of the difference between that, right? Religion is a system of beliefs, practices, and ethical values. So, like Catholicism, Orthodox, Islam, Methodist, Protestant. Whereas we know spirituality is more about the individual and maybe just believing in a higher power, that you're not necessarily associated with a specific religion. So you can be both, right? You can be spiritual and also maybe be associated with a specific religion and be religious, okay? Because some can believe in both, right? Believe in a divine or superhuman power that's beyond yourself. So religion is a much more organized system of beliefs where we're meeting certain groups, people, where spirituality is more individual, and you don't necessarily have to be associated with a specific religion to be spiritual. Socialization is the process of being raised within a culture and acquiring specific characteristics of that group. And so there are specific related terms with that, right? Acculturation, assimilation, biculturalism, culturative stress, and culture shock. I'd be kind of just a little bit familiar with those terms in relations to socialization. Okay, so if people, immigrate or migrate to the United States, it's how much they've started to take on the dominant culture of where they're living now, or are they somebody that's capable of still holding on to some of their own culture and their tradition, and yet, assimilating or still being able to, live successfully with the dominant culture where they're at. So be a little bit familiar with the related terms to socialization. So health-related behaviors affected by religion, and there are vast. I'm sure there's much more than what's just listed here, right? So meditation. We know for some that might be something we've incorporated into more westernized traditional healthcare, the benefits of lowering our blood pressure, lowering our heart rate, reducing stress. But we know some of it is very much associated with religion. And this is going to be sometimes done, throughout the day or more during times of specific months of that's associated with a religion where they're going to be doing it more often. Vaccinations, we said, can be affected by religions. Willingness to undergo physical exams, especially by people of different genders, that could definitely be affected by religion. Their feelings about privacy and modesty. And then truthfulness about how a patient feels. We talked a lot about being stoic or expressing their feelings. That can go on different ends of the spectrum where people, are always going to want you to think that they're okay and then that they're not in pain, and they're going to want to give you information they think that you want, versus others are going to be much more expressive and tell you maybe more than you need to know. They're going to start to cross those professional, personal boundaries. Genetic screening and counseling, and then living with a disability and care for children. So there's a lot of different areas where religion can affect health-related behaviors. All right, so steps to cultural competency, right? So being culturally sensitive. So, it's not realistic to say that we're going to know about every specific culture in great detail when patients come in through the hospital or through a healthcare agency. but we can be culturally sensitive. So we possess basic knowledge or a little bit of awareness of diverse cultures that come through, at least enough of awareness that we know that there could be an issue, okay? And then culturally appropriate. So maybe we take that basic knowledge, we do a little bit more research, we learn a little bit more about that specific culture, and we implement culturally appropriate care in order to improve health outcomes or patient satisfactions. And then the next step is we're culturally competent. So we consider all aspects of the patient's culture, so their immigration status, stress, the social factors, cultural similarities and differences, and we apply a universal concept of understanding to all of these aspects of care. And then cultural care is just the provision of healthcare across cultural boundaries. So sensitive, very basic knowledge, culturally appropriate, trying to take a little bit more of that basic knowledge, learn a little bit more, implement culturally appropriate care, and then cultural competence. There's some other steps to cultural competency, and I think you can find this in a lot of, probably in the textbook, but this is an important component for you to remember. So I think in order to be able to provide cultural competent care, you need to understand your own heritage-based values, beliefs, attitudes, and practices. So what is your cultural? What is your culture? What do you believe in? What are your traditions, values? We need to identify the meaning of health to the patient. Need to help them understand we need to understand how the healthcare system really works. Acquire that basic knowledge. Remember, being culturally sensitive about specific backgrounds of patients. And then I think definitely this is a much more realistic expectation of cultural competence, is to become familiar with the resources that we have, like the interpreter services. What is, how do we contact interpreter services? How do we do this from a very efficient, streamlined issue so that we can do this for the patient, timely, to make sure they're not waiting. So like we said, culture and respect. So how can we implement cultural care? Obviously making sure that we know our heritage, the culture of ourselves, basic knowledge of our patient. Examine the patient within their cultural context. And especially this falls in line if patients have limited English proficiency, selecting simple questions, speaking slowly, watching our pace, and following the patient's cues when we are examining them, and then we're collecting specific data to know if it's starting to make the patient uncomfortable or if they're shutting down, and maybe we've crossed a boundary. Okay, so looking at cues. We want to encourage our patients to discuss their meanings of health and wellness. And then obviously checking to make sure the patient has understood or they've accepted, the recommendations that we've given them. And then touch, we said, is within the boundaries of their culture. And so some of the cultural competence questions that, that you may see in the complete health history that you guys worked on yesterday, or that you'll see in specific hospital affiliations is, where does the patient come from? Under what circumstances? How long have they been here? What is their heritage, their cultural background, ethnicity, and then religion? Does the patient understand, speak, and read English? We know that has a big deal with health literacy. So patients may speak English, maybe it's somewhat broken, maybe it's not fluent, and so they have a difficult time understanding the nuances of the English language. So they may be able to read and write and read what's right in front of them, but they may not understand it from a broader concept and be able to implement it safely to improve their outcomes. What specific language do they understand, speak, and read? And what are their specific health and illness beliefs and practices? Are they in line with the more Western traditionalized system, or they are more natural, such as the yin-yang, the cold and the hot, or are they more from a supernatural forces?